Okay, welcome everyone to our UCSD high rounds. I'm Daniel Lee, clinical professor of medicine here at UCSD at the Owen Clinic. I'm going to be your moderator for today. And before I introduce our speaker, Dr. Sanjay Mehta, we wanted to acknowledge our infectious diseases and global public health um, fellowship candidates. And so we wanted to welcome the following applicants, which we have today. So Dr. Esteban Martinez, Dr. Ali Abdul Karim Abdul Sahib, Dr. Panjun Patel, Dr. Aisha Sundaram, Dr. Rachel Tenney, and Dr. Jenna Wick. So welcome to all of you, and good luck on your interview day today. So I have the pleasure of introducing Dr. Sanjay Mehta. And so originally I wasn't going to be the moderator for today. And I didn't get a bio initially from Sanjay. And so I asked him, do you want me to just make up a bio? And he said, yes. So I'm going to have just a teeny bit of fun with Sanjay. Parts of this story are real, parts of the story are not. And I think it's up to you to figure out which is which. So, are you ready, Sanjay? Okay.
Go for it.
Don't be scared. So, I was in the shower and thinking about what I was going to say today. So, Dr. Sanjay Mehta was actually born in the woods. He was found and taken to Hogwarts School of Wizardry, where he learned magic as a muggle, so a non-magical family. And so he learned many, many different spells, and that led him to a secret career of being a secret spy for the U.S. And so part of his time he does that. On other parts of the day, he actually so Hogwarts School in Cleveland. Yes, that was a different branch, I see. And so eventually he made his way west from Cleveland. Actually, he went to Johns Hopkins for college, then Case Western for medical school, completing his residency at the University of Colorado. Eventually, following the smell of fish tacos, he came all the way to San Diego, where he regularly eats fish tacos. So he's been trained in internal medicine and infectious diseases. His research interests are in the intersection of tropical medicine and HIV. So that allows him to travel around the world doing his secret adventures in the guise of being a professor. He also studies in the molecular epidemiology of HIV and the intersection of aging and HIV. After starting his infectious disease career, studying the intersection of HIV and malaria at the University of Maryland, he transferred to UCSD to begin working on translational and basic approaches to better understand HIV and leishmaniasis co-infection in Brazil, which he had himself and then subsequently cured himself. In San Diego, he soon became involved with the strong clinical and translational HIV research program at UCSD, and is currently studying the application of molecular epidemiology techniques to tackle HIV transmission. In addition to his other job of fighting crime, he is currently the infectious disease section chief and director of the clinical microbiology lab at the San Diego VA. And so his favorite spell is something called mesmerismo. It's to mesmerize attendees to his lectures to stay awake and absorb the information that he's about to tell us. So beware of that. Welcome, Dr. Sanjay Mehta.
Thank you so much for that introduction, Dan. I guess my cover is now blown.
Yes.
But must switch careers at this point. Awesome. Well, welcome again, everyone. Thanks for taking the time to listen to me. So I'm going to talk about HIV and longevity, and I've kind of talked about this every couple of years. The work or the lecture today is really based on other people's work. I'm definitely interested in this field, but I'm not doing as much in this field at the moment. But hopefully, I can excite all of you as much as I'm excited about this space. Let's see. All right, so longevity. So aging is that progressive event-dependent decline in our ability to maintain biochemical and physiological function. So, obviously, as you get older, you think more about this stuff, and maybe that's what's going on in my mind. But what's probably more important is not so much how old you get to, but how healthy you are as you get older. And that it's really what we call as the health span, which is the part of a person's life during which they're in generally good health, as opposed to the lifespan, which is essentially just the time a person lives. And longevity is actually defined as the length of the lifespan, but kind of what we're mostly interested in is the longevity of the health span. We want to get people to live as long and as healthy, in a healthy state for as long as possible. And this is, becoming an issue not only in persons living with HIV, but in lots of other chronic infectious diseases, which kind of drive the aging process. And we'll talk more about that here. So what defines our health span? So is it just the life with the absence of disease or infirmity? You could think that way, but it's a lot more complex than that. So there are social, mental, and physical components to our health span, and they all interact tremendously with each other. And so you can't just focus on the physical and not focus on the mental and social and vice versa. These things are very, very, very much intertwined. And just for example, you can kind of think of these are just very specific examples of how these guys are intertwined. So our physical health can drive our mental health, because we know that inflammation that gets into our brain can cause depression, and that depression obviously affects our mental health. We know that as our physical health declines and we get frail, we don't go out as much, and that leads to isolation, which impacts our social well-being. Similarly, in terms of mental health, depression leads to people being less active and progressive frailty. Similarly, depression also may lead to people isolating from other individuals and impact their social health. And then social well-being, if you're not in a good social place, you tend to isolate yourself, which leads to decreased activity, which again can lead to frailty. And similarly, isolation itself can lead to depression because you're not interacting. And so these are highly intertwined factors. For the talk today, though, I want to focus really on the physical, and other people have given talks on the mental and social aspects of aging and how to combat those, and especially in our aging people living with HIV. But here today, I'm going to mostly focus on the physical side. So on the physical side, if you drill down to the level of the cells, there's a handful of sort of cellular level dysfunctions that we know are associated with aging. And we know that as cells get older, their genomes become a little bit more unstable. They have more issues and require more repairing. We know that as cells kind of reach their division limits, they have attrition of their telomeres, which are the ends of the chromosomes that are kind of have extra repeats on them to kind of handle repeated division. We know there are epigenetic alterations in the genomes of these cells. We know that they don't handle proteins as well. Sometimes those proteins accumulate, such as in diseases such as Alzheimer's. They lose their ability to regulate the nutrient sensing. There's mitochondrial dysfunction, which affects our functionality. Then there's direct cellular senescence, and then there's exhaustion of our stem cells, and finally there's changes in communication between cells. And all of these factors that are occurring at the level of the cell lead to phenotypes that we all know that are associated with aging, which include sarcopenia, frailty, cognitive impairment, dementias, cancers, atherosclerosis, diabetes, osteoporosis, OA, renal dysfunction. And these also have impacts on our body's ability to rebound or its resilience from other insults, such as infections, wounds, toxicities from external things, including chemotherapy, etc. So at the cellular level, we talked about cellular senescence, and I talked about all these things that are occurring at the cellular level. And they're not sort of independent of each other. They all kind of interact in some way. And so we know that these epigenetic factors, telomere erosion, DNA damage, mitochondrial dysfunction, these are things that can be impacted by outside factors, and they can drive cellular senescence. And once you have senescence, in addition to that, things like nutrient dysfunction and proteostatic dysfunction, so protein handling can also drive cellular senescence. But once that cell becomes senescent, we know that it's functional, there are functional changes as well, which also impact proteostatic handling, nutrient sensing. And then senescent cells are poorly functional in terms of the way they divide. And so they're exhausted. They don't divide like typical cells. And if they're stem cells that are senescent, they can stop dividing. And then senescent cells also have a unique phenotype sometimes where they produce a lot of inflammation. And we'll talk more about that in coming slides. But the issue really here is that these senescent cells increase with age, and they increase in disease tissue versus age-matched healthy tissue. So they accumulate. So what else drives senescence? So we talked about all these sort of cellular level factors that drive senescence, but there's environmental factors that clearly drive senescence in our cells as well. So radiation, whether that's direct radiation from a cancer therapy, or just UV radiation that we're spent too much time out in the sun, chemotherapy, so drugs that we're prescribing to individuals, infections can drive senescence, other environmental factors such as pollutants, cigarette smoke is for example. And then there's underlying genetic conditions that can drive senescence as well. We call those progeroid conditions. All right, so taking a step back, what about HIV? Why is this so important in our persons living with HIV? So we do know that HIV accentuates aging, and you've all probably heard this many times. This slide's probably been presented a handful of times already, but I think it's a really important one that just to kind of see. So here on this slide are 9 different sort of aging-related syndromes, from myocardial infarction to osteoporotic fractures. And in the red is the increasing risk in HIV individuals, and in blue is the risk over time in control individuals, so HIV uninfected individuals, and that the adjusted risk, or the between the two, is the line in purple, and you read that result on the right-hand y-axis. And what you can see is, yes, with pretty much everything, as you get older, you get progression of these age-related conditions, perhaps except for the chronic liver disease kind of looks a little odd, but everything else is kind of going upwards. But you'll notice that for the most part, the rates among the HIV population are higher than among the controls, as we've heard over and over again. But what you'll see in the line in purple is that risk actually is much higher early on in younger individuals. It kind of decreases with time, and presumably treatment, as people get older. And so it's not, while that increased risk doesn't go away, that accentuation of aging doesn't go away, it definitely decreases with time. And we also know that HIV accentuates frailty. And this is a study from a cross-sectional study from the Women's Interagency Study, or sorry, a cross-sectional analysis from the Women's Interagency Study. They looked at the Freed's Frailty Index, which is an index that kind of looks at mobility, grip strength, physical exhaustion, weight loss, activity. And they did a cross-sectional analysis across their population, and they found that frailty was associated with lower CD4 counts, prior history of smoking, lower income, injection drug use, and then other health-related factors that you might be expecting. So, but it was clear that HIV independently was a risk factor, particularly with low CD4 counts. So this accentuation of aging, people have found ways to kind of quantify this a little bit. And these are some interesting approaches that have kind of taken hold in the aging field recently. And so what this slide is it's kind of looking at 4 of these sort of approaches, and these are what we call epigenetic clocks. So we know with time, with age, we have epigenetic changes in our genome where our genome gets increasingly or decreasingly methylated. And that methylation is kind of a way for our genome to kind of turn on certain genes and turn off certain genes. But because it's such a clock, there's such a clock-like signal in the rate of these methylation events, we can actually estimate someone's epigenetic age, or we can estimate someone's age from their DNA. And that correlates, and they've done this, and they've been able to correlate it really well to the chronologic age. So then you can say, hey, if that is shifted, where there's the epigenetic changes suggest that someone's actually older than they are, and they've had accentuated aging, versus if the epigenetics changes suggest that someone's younger than they actually are in terms of chronologic age, then maybe it's decreased aging. So these are 4 of those clocks, and what you'll see is that they all kind of parallel the dotted line, which is essentially what we would want for a perfect clock in a normal individual. But what you'll see is that there's kind of when you look at the persons without HIV, you do see some initial starting away from the line and kind of bending towards the line, or not bending, but movement towards the unity line. And then if you look to the far left, so this is the patients who were seen at baseline, you can see that there is probably a little bit of a shift upwards. So there is an increase in the epigenetic age versus the chronologic age. But again, there also that line is actually, as people get older, it gets closer and closer to unity. And then 96 weeks after the initiation of therapy, that line gets shifted closer to the unity line. And so that, again, showing that while aging is accentuated with an HIV infection, with treatment, that a lot of that accentuation does improve. And this is just kind of quantified here. You can see the estimated age acceleration is the y-axis. And if you look at the far left on the Horvath clock, with baseline being the control being HIV negative and 0, you can see that at baseline, individuals had an age acceleration of 2.5 years, and after 96 weeks of treatment, looking at their epigenome, that was only about 1.5 years. Similarly, with the other approaches, the numbers vary a little bit depending on the actual clock used, the epigenetic clock used. All right, so we can measure accentuation of aging. HIV individuals, unfortunately, do have accentuated aging. So what's causing this? What's driving the accentuated aging in our persons living with HIV? So there's a number of different factors that these individuals experience. So one is the HIV itself. So there's direct toxicity from the virus. The virus is driving inflammation. It's driving, the immune response, which is maybe potentially accentuating aging through inflammation. Then there are the antiretrovirals. So we know that the antiretrovirals, many of the original ones, were particularly mitochondrially toxic, and we know that mitochondrial toxicity has been associated with accentuation of aging. Then there's inflammation from other causes, from things like gut translocation, from things like reactivation of latent viruses, etc. And then unfortunately, we know in our population that there's a higher use of substance use, and substance use can drive accentuated aging. Particularly in our older individuals, there's more social isolation, and there's a lot of polypharmacy, which maybe drug interactions themselves are driving some of the issues. So we do have ways to address these. So, for HIV, we get people on ART and we sustain them on ART, and that hopefully limits the direct HIV toxicity. The newer antiretrovirals, particularly these integrase strand transfer inhibitors, are remarkable in their reduction in toxicity, or reduced toxicity compared to the original meds. I'm going to skip inflammation. For substance use, we have mental health and addiction treatment. For social isolation, there are approaches to build communities or mini villages within groups of individuals to kind of help them deal with their isolation and losing loved ones. And polypharmacy, as our patient population gets older, we're having to spend more and more time incorporating geriatric principles, try to do less harm as opposed to treat everything. But what I'm going to focus on here, and as this talk goes on, I'm kind of drilling down towards a specific topic, and we're going to focus on inflammation. So I don't know if you guys have heard the term inflammaging before, but it's a term that people are using to explain how inflammation drives the aging process. And so, as we talked about, there are a number of things that can cause the inflammation, and that inflammation can trigger more and more processes in a feed-forward mechanism. And that feed-forward mechanism causes more inflammation, which eventually causes tissue damage, which causes more inflammation, and eventually that inflammaging process leads to physiologic outcomes, such as the age-related outcomes that we've talked about, such as frailty, diabetes, obesity, atherosclerosis, cancer, etc. Well, let me skip that for now. So what are the causes of inflammaging in persons living with HIV? So we, kind of going back to that list, if we focus on inflammation in that list, there are a number of things that can drive inflammation. I think I didn't mean to press that button there, but so we have HIV replication. So we know that, replicating HIV drives inflammation itself. So getting that under control reduces inflammation. There are chronic co-infections. So a number of our individuals are co-infected with other viruses, classically HCV, although we've done a pretty good job of getting most of these individuals treated. Then there are viral reactivations. So, most individuals living with HIV have at least 1 or 2 or 3 herpes viruses that have become latent. And sometimes with stress, sometimes with a poor immune response, those viruses reactivate. And those viruses, the reactivation of those viruses actually drives inflammation as well. There's microbial translocation. We know that early on in HIV infection, there's a huge loss of gut CD4 cells, and that affects the integrity of the intestinal wall, allowing microbial products to translocate and drive inflammation that way. There's gut dysbiosis. We know that individuals living with HIV have abnormal microbiomes frequently, and those abnormal microbiomes are associated with inflammation as well. Then there's immune dysregulation itself, the increasing cell senescence and cell death, and then obesity and metabolic changes. And so, again, we'll kind of drill down on the immune dysregulation. And, please feel free to type in the chat. I'll have the chat open if anyone has questions about anything. All right, so what can we do to inhibit or stop this inflammation in our HIV infected individuals? So we can limit exogenous stress. So how do we do that? Things like trying to get people off of street drugs, mindfulness work, things along those lines can limit exogenous stress. It decreased the antigenic stimulation. So things like those latent or reactivation of latent viruses that we talked about. There are trials ongoing right now to look at the impact of medicines to kind of suppress those viruses. And I won't get into that further as there are others in our division that are working on that. But one example is a trial of using letermovir, which is an antiviral, to suppress CMV in these individuals to see if that impacts the inflammatory state. And then there's trials of anti-inflammatory agents. So there's a trial ongoing of canakinumab. And then most of you have heard now of the Reprieve trial, which was just published a couple of weeks ago, which looked at pitavastatin and its role in reducing cardiovascular events in individuals living with HIV. And there was definitely a positive signal in that trial. I think there's going to be a talk on the Reprieve trial coming up soon, so I'm going to leave that alone as well, or not too much. Then there's antioxidants. So for a long time, people have tried using antioxidants, vitamin E, vitamin C, to reduce inflammation. Most of those trials have not really panned out. And there's increasing autophagy. So autophagy is the process by which our cells mop up. The way I think about it is they mop up damaged cells. And so by clearing damaged cells, that potentially you might be able to reduce inflammation that way. Then there are approaches to block senescent cells. So senescent cells, not only are they kind of tired and they don't work as well, but they also release factors that can trigger other inflammatory processes. So if you can block those inflammatory processes, you might have an impact on inflammation inhibition. And you can also just go out and kill those senescent cells. So the drugs that block senescent cells are called xenomorphics, and the ones that kill senescent cells we call senolytics. And we're going to kind of drill down particularly on those. But let me just kind of quickly run through these other inhibition approaches quickly. So I said I wasn't going to spend too much time on the statin, on the Reprieve study. Well, I do have one slide. And this is just, kind of the major figure from the study. You can just see that the cardiovascular events rates among individuals who received pitavastatin versus placebo, and the rates were significantly lower when looking at first major adverse cardiovascular event. And when you include death in that combined outcome, there was a little bit of overlap in the confidence intervals, but a trend towards a difference. Then the CMV suppression with letermovir, again, as I said, there's other people in our division working on this study, Sarah Ginella in particular, and since the ACT left out the G5383 study, which is essentially looking at the ability of letermovir to act as an anti-inflammatory by suppressing CMV. The canakinumab study, canakinumab is an IL-1 beta inhibitor, and that one is still in process as well. I think maybe the study's complete, but the results are not out. Yeah, so that leaves us with these last two things, which is what I want to focus on, just xenomorphics and senolytics. So getting back to these senescent cells. So these senescent cells have kind of a handful of hallmarks. They are withdrawn from the cell cycle. So they have anti-apoptotic pathways that are turned on. So they don't die as easily. They're kind of hanging out. Even though they're senescent, you would think they might die easier, but they actually are less likely to apoptose on their own. They have macromolecular damage. Sometimes that's what's driving the senescence. They have dysregulated metabolism. Sometimes they're chewing through energy at a quite high rate. And then many of these cells have something called the secretory phenotype. And we'll talk more about that later. So this secretory phenotype, or this senescence-associated secretory phenotype, or SASP, is a pro-inflammatory state that senescent cells have, where they release a lot of inflammatory molecules such as IL-1, IL-8, TNF-alpha, and matrix metalloproteinases, and those are enzymes that damage tissue. Again, they also have that anti-apoptotic state, so they kind of hang around. So if you kind of look at this sort of circular figure, you get a stress event, which induces senescence in a cell. That cell converts over to a senescence-associated secretory phenotype. It starts spewing out these inflammatory molecules. Those molecules actually act in a paracrine fashion to make other cells nearby senescent. And so you get accumulation of these senescent cells, which drives inflammation and sort of works in a feed-forward loop. So if your immune system is working well, it will clear those senescent cells before you get too many secondary senescent cells, but sometimes that doesn't happen. So when you get this sort of feed-forward mechanism of senescent cells, people have shown that in specific tissues, you can the proportion of senescent cells is associated with aging-related outcomes. So, for example, if there's a higher proportion of senescent cells in smooth muscle and endothelial cells, you get cardiovascular disease. In astrocytes and microglia, you get Alzheimer's disease, and that's what these figures here on the right are representative. So, P16INK4A is a marker of a senescent cell. It's kind of a marker of kind of a block in cell cycle, in the cell cycle. So these cells are kind of have upregulated anti-apoptotic pathway. So you can see that those cells kind of accumulate with time, from fetuses to 35 to 50 years to people in their 70s, late 70s and 90s. Or 70s to 80s. But then when you look at age-matched controls of those with Alzheimer's disease, you can see that those with Alzheimer's disease actually have even higher rates than age-matched controls of these senescent cells, particularly among their astrocytes and microglia. Similarly, for osteoarthritis, chondrocytes, you see a higher proportion of chondrocytes that are senescent, and those are sort of stained in brown on this figure here, and this is sort of the degree of arthritis, and then correlates with the percentage of beta-gal positive cells, and beta-gal positivity is another marker of senescence. See that a lot of our sort of processes that we think of with aging are often associated with the presence of senescent cells in particular tissues. Oops. All right, so what about Senolytics? So really, Senolytics, the origin story of Senolytics was probably in 2011 when this work with by Baker et al., where they looked at mice that have this aging phenotype. And they found that if they could take out the cells that were expressing that P16INK4A kinase, they could reverse the accelerated aging. And so kind of maybe we'll start with panel C. You see those two mice, and the top one is a healthy one, and the bottom one is what we call a lordotic mice, or a mouse that's kind of been aging or had accelerated aging. And you can see in figure or panel B, so they essentially added a gene construct and then added something that will trigger that gene construct. So if you looked at the dotted lines with the in blue and red, both of those are mice that received the gene construct that took out those cells and the activator. And you can see that the lordokyphosis incidence and the cataract formation incidence was markedly less than in the control mice, with the control mice being these progeroid mice. So the idea here was, wow, if we just take out these cells, we can reverse some aging-related phenotypes. Right. Obviously, this was gene therapy in mice, not something that was straightforward to do in humans at the time. And so this is kind of how the model was put together based on this work and some other work after that. That you have cells and then you have some sort of stimulus that drives senescence in those cells, and that senescence triggers potentially the SASP phenotype. And if that senescence continues and it passes over to the immune cells, then you get immune activation, and that immune activation leads to age-related diseases. And you can clear those senescent cells out using Senolytics. You can block the SASP phenotype using Xenomorphics. And if you do it long enough and you clear out those senescent cells, that you kind of regenerate the tissue and you get back to healthy tissue. Now, there's a reason that we have these pathways, and so blocking them may have adverse effects. And kind of the reason that we have these pathways is for wounded tissue repair. And so that's this bottom piece of the panel. And, these inflammatory cells do help with wound and tissue repair. They do help with tumor protection, and they actually are important in embryonic development. So there's been a little concern that maybe we're going to by using Senolytics we might actually increase our rates of cancer. But this is sort of how the model's been put together. So Senolytics. So we talked about that proof of concept in mice. So now people have started to figure out there are medications, there are drugs out there that preferentially increase the apoptosis of SASP cells, so senescence-associated secretory phenotype cells, because they have upregulated anti-apoptotic pathways, they have associated mitochondrial dysfunction, and there's ways to kind of target those aspects. And a handful of these meds include quercetin, which is a flavonoid compound found in apples, fisetin, a flavonoid compound found in strawberries, and dasatinib, which is a tyrosine kinase inhibitor. These are probably the three that are most well known at the moment, but there are actually many more now. Again, these are not meds that you can just eat an apple a day, keep the doctor away. It would take like a bushel of apples to get enough quercetin to have the impact that you want, and multiple pints of strawberries a day, which some of us wouldn't mind, but be difficult to do. So here's another proof of concept of this Senolytics and how they work. So this was a mouse study where they took two mice that were 6 months old, and in one of them they injected senescent cells, and another one they injected control cells. And then they measured physical function after a month. And you can see here that there's, they looked at 6 different aspects, and really one of the ones that we've kind of noticed for a long time that's associated with aging is your walking speed and your grip strength tend to be really important in aging, or great ways to measure aging. And so in these mice, they found that with the number of senescent cells they injected into the mice, they had a decrease in maximal speed of walking. They had decrease in hanging endurance, which is another way of measuring function in mice. And they also had a decrease in grip strength, but really no change in their food intake, no change in their body weight, etc. So just adding senescent cells into a mouse made them functionally essentially less active, less functional. And then they kind of took the next step, and then they treated these mice with Senolytics. So in this case, the Senolytics that they used were dasatinib and quercetin. So 2 of the 3 that I showed you on that prior slide. And so here they took mice and they added senescent cells like they did before. And then in some of them, they treated with these Senolytics. And you can see here that if you look at panel D, the maximal speed of walking from the control, and the ones that receive the control cells, the ones that receive the Senolytics, the senescent cells. And then in red are the ones that were treated with these Senolytics. And you can see that just with that maximal speed, the ones that were treated with Senolytics almost went back to baseline in terms of their maximal speed of walking, in terms of their hanging endurance, in terms of their grip strength. The treatment with those with the Senolytics really made a big difference. And we don't need to look at the bottom slide. I'm going to skip over that. So then people started thinking about, well, how might this work in other situations? So what about in inflammatory conditions that are temporary, such as COVID? So this was a study where they used a mouse SARS-CoV-2 model, and then they essentially gave them DQ, and then they infected them with SARS-CoV-2, and then they gave them a little bit more DQ, and they showed that they were able to protect the mice from, so they had a dramatic decrease in, dramatic increase in survival. They had a reduced weight loss, and that panel C on the left is the viral load. You can see the viral load actually wasn't that different between the two. So it wasn't a antiviral effect. It was a different type of effect. In another similar study in hamsters, they same thing. But this time they actually only treated the hamsters with these senolytics after the infection with SARS-CoV-2. So in that previous study, they gave them a little bit of senolytics, they infected them with virus, and they gave them more senolytics. Here, the DQ was given only after the infection with SARS-CoV-2. And you can see on the panels here, where solvent is just what the meds were mixed in. You can see that there's massive inflammation in the panel with the pneumonia. There's a lot of endotheliitis and a lot of bronchiolitis. There's lots of purple there. The Vitaclax is just another potential senolytic, and it had some effect, not as much as the DQ, which looks essentially almost normal compared to the mock, right? So the DQ really did have a dramatic effect in reducing the inflammation in the lung in this hamster model of SARS-CoV-2 infection. All right, so what about in humans? So there have been a handful of trials of senolytics in humans to date. This was kind of the first one in 2019. It was an open label, single arm trial of 14 patients. So again, open label, so take it with a grain of salt. These are all individuals with pulmonary fibrosis, and they looked at their baseline 6-minute walk distance, and then they treat them with DQ, and then they look at the change in 6-minute walk distance. And what we're looking for here is that if there was a positive effect, you'd see most of the dots would be above the unity line. And that's pretty much what you see, where the vast majority of the dots were higher. So they actually increased their follow-up 6-minute walk distance after treatment with DQ. And more importantly, the speed seemed to really significantly increase, again, in this 14-patient open label trial. So they were able to potentially reverse some of the impact of the pulmonary fibrosis. This was a study where they looked at diabetic kidney disease, and here senolytics decreased the inflammatory markers in persons with diabetic kidney disease. So on the top panel are a sort of measurements at baseline of a bunch of inflammatory cytokines and matrix metalloproteinases. And you can see that they're all fairly high in persons with diabetic kidney disease. And then this is 14 days. This is after the treatment with DQ, and they're kind of almost all shifted down quite a bit. So the senolytics really dramatically decrease the inflammation in these individuals. All right, so that gets me to kind of really where I want to go here. So what is the role of senolytics in infectious disease and in HIV? What are the roles of senolytics in infectious disease and HIV? So as we talked about, senolytics have the ability to potentially reverse some aging-related processes, at least in mouse models, in a handful of human studies. We know that in infectious diseases, particularly severe infectious diseases and chronic viral infectious diseases, we're getting a lot of inflammation, and maybe that's impacting people long-term. So how do we potentially use these drugs in infectious diseases? So kind of another kind of model that was presented by Lee et al., which kind of talks about how when you have normal senescent cells, they increase with age, you get the SASP, and you get organ damage and tissue dysfunction. But what about with viruses or infections, pathogen-associated senescence? So if things are working well, like in a young host, you do get some senescence, you do get some immune response, you do get some SASP, but that's all part of the antiviral or antipathogen process. And then that promotes the tissue repair afterwards. However, sometimes that's going to go awry, and that's going to trigger the excessive responses that are seen with aging, and the excessive SASP, the excessive immune responses. And so, kind of how do we use this drug in a way that's going to not limit the positive effects of senescence, but limit the negative effects of senescence. So this is kind of where we're at. We're still not sure really how to do this, but people have started in people looking at this, and so one of the kind of the first set of studies where people have used quercetin in humans were in COVID. And so quercetin was tested as an oral formulation with sunflower lecithin in 2 randomized controlled, but they were open label clinical trials with a total of 194 patients. And what they did find was that the individuals that were treated with quercetin had a reduced frequency of hospitalization, a reduced frequency of need of oxygen compared to the controls, the standard of care patients. And on the left, you can see between groups that there was a dramatic difference in hospitalization days in ICU, the percentage of patients in the ICU, and the percentage of patients that died. So again, these are small trials, and probably a lot of other factors were involved that needed to be controlled for. But this is another potential use for these senolytic drugs, kind of in these runaway inflammatory diseases like COVID. Of the drugs that are kind of out there that are under investigation in humans right now, I showed you a handful of studies, but these are the drugs that are really out there. Metformin is a xenomorphic, NR and NMD are NAD sources, so they're sort of another approach to xenomorphism. Rapamycin or sirolimus and its analogs are being tested as xenomorphics. DQ we talked about, which there's already been a few studies. Fisetin, there's a number of studies ongoing. There's a whole host of studies using other natural products which may or may not have significant senolytic or xenomorphic activity, like curcumin. And there's a whole host of clinical trials registered on clinicaltrials.gov looking at these drugs, looking at chronic kidney disease, skeletal health, frailty, osteoarthritis, COVID, long COVID, etc. But what about HIV? So there was one study of senolytics in individuals who had renal transplants and HIV, and they looked at what if individuals got sirolimus, which we talked about as a xenomorphic agent, compared to tacrolimus and cyclosporin, and they looked at the proviral DNA in those individuals. So this is kind of the viral, proviral load, the DNA viral load in these individuals. And there seemed to be a signal where there was a lower viral load in those individuals getting sirolimus. And when you compared individuals that got the other suppressive medication, cyclosporin or tacrolimus, there did again seem to be a signal that maybe these drugs are actually going to, not only are they anti-inflammatory, but they might help actually reduce the actual proviral load. And in the opposite manner, there was a drug tried, panobinostat, which is a HDAC inhibitor, which was used to sort of activate cells to, as part of the shock and kill approach, right, to reverse latency so that those cells would be killed off to kind of reduce the proviral load. But strangely enough, in addition to increasing viral replication, it reduced inflammation. And kind of further studies have shown that panobinostat actually has a senolytic effect, so that maybe it's actually taking out some of the senescent cells in addition to causing a reversal latency of the HIV. These are just measures of the inflammation. So soluble CD40, ligand, MMP9, all those kind of went down. IL-6 kind of went down a little bit as well. with panovinostat. So what's going on in HIV right now? So there's been a few other trials of these senolytics in HIV. Quercetin, there's been a small study in mice, and they showed that quercetin was able to inhibit the AZT-induced neuroinflammation in mice. Venetoclax was able to selectively kill HIV, which is a BCL2 inhibitor, which is also considered a senolytic. It was able to selectively kill HIV-infected cells, resulting in a decreased proviral load. And dasatinib and quercetin of D&Q did inhibit HIV replication in CD4 cells. So there's kind of this little bit of work here and there in the space. So kind of the big goal is like, you know, how do we really use this, and kind of how do we make this, how do we use these drugs in HIV? And so this is sort of the model approach that the people working in this space are using. So they're using what's called the geroscience guided approach to HIV and aging, where you have normal aging. So this is the incidence of aging-related conditions with age. And if you use geroscience interventions, that you can hopefully reduce those things that are affecting your health span. And we know with HIV, all that stuff occurs earlier. There's this accentuated aging with HIV. But if we use a geroscience guided approach, hopefully we can either shift that back to normal aging or potentially even better than that. And that's where we come to finally the trial that's in process right now. So this is the first clinical trial of senolytics to improve actual physical function in persons living with HIV. This is a phase 2 multi-center 36-week randomized double-blind placebo-controlled trial of DQ versus placebo that's being run through the ACTG. Dr. Latender, I don't know if he's on today, is helping out a little bit with that trial. Essentially what the trial is going to be is two groups of 35 individuals, and one group is going to get DQ every 14 days for 12 weeks, and the other is going to get placebo, and then they're going to measure a whole host of functional outcomes and see if there is an impact. So I think that is all I had. This is just kind of their endpoints. So the inclusion criteria are important here. So it's not only just anyone living with HIV, but you have to be over 50. You have to be on ART for greater than 2 years. And you have to be either pre-frail or frail by the frailty phenotype, and have a gait speed that's between 0.5 and 0.2 meters per second. And then in terms of what's being measured, safety and tolerability, the change in gait speed, and then a number of sort of other secondary endpoints, but which include physical function endpoints such as time chair stands, physical function, and then also these inflammatory endpoints like senescent cell abundance, the SASP, composite biomarkers, etc. So yeah, I'm excited. That's why I wanted to present this. I'm not participating, but I'm really looking forward to the results of the study and seeing if there's sort of an alternative approach to our management of our patients. And I think there's just a few other trials that are going on around the world. I'll skip that. So yeah, so maybe we are finding ways to delay death using dates. I don't know. So let me actually look at the chat. If anyone has questions, feel free to just chime in, but hopefully you got something out of that. So Nettie says, let's see, we have lots of experience with the benefits and risks of broad anti-inflammatory agents. It seems the benefit of these senolytics is that they're more targeted, but I'm curious about short and long-term complications. Can you talk more about that? So it's a great question, Eddie. I think there isn't a whole lot of data yet on these long-term complications. In terms of short-term, there are typically there's some GI effects from D&Q, so they're fairly well tolerated. But the long-term effects, right, are you going to impair wound healing? We know that sirolimus, when we give people sirolimus, it causes wound healing impairment. And so people who are getting sirolimus for transplants, they typically get taken off of that if they're going to have another surgery or if they have a major traumatic event. Probably there's going to be something similar going on with these other agents as well. Scott, yeah, Scott knows his stuff. Don't don't listen to him being a psychopath. The past couple of weeks from memory, I'm not sure what that is. Maybe Scott, do you want to share that news story?
Yeah, so it's they presented findings at the Brisbane meeting on ruxolitinib and another ACDG study, and found that I think 5 weeks of treatment substantially reduced the HIV reservoir. And I mean, it's relatively small sample size at this time, or a small sample size. I think just a handful of patients, but it was an impressive effect considering the size of the effect that effects that have been observed so far with other interventions. So to the extent that clearly reducing the HIV reservoir is important for cure, to the extent that it's valuable for sort of reversing the trend toward premature aging, all the better. So early data, but encouraging for JAK inhibitors.
Yeah, there may be multiple benefits from these agents. It's fantastic. Thanks, Scott.
Sure. Nice talk, Sanjay. Sorry I came on late, but what I saw was really good. So congratulations.
Oh.
Any other thoughts, comments? You can open it up. Well, I think this is certainly a pertinent talk, and clinically, I think we obviously see the challenges with our population as they get older. I think definitely we're seeing much more issues in terms of frailty, as well as more of these kinds of aging changes. And so I think looking forward to seeing some of this data with these Senolytics. So. All right. Well, I'm going to go ahead and close it. Oh, Scott, comment?
Yeah, sorry, before we close, I'll just jump back in and just say if folks are interested in this, Miley Karras is doing a lot of work in the Owen Clinic in this area. And we have an HIV and aging working group in the ACTG that we'd welcome involvement in. And we also have an HIV and aging training program. If you have any postdoctoral students or junior faculty who are interested, it doesn't pay salary, but it provides training and mentoring and resources to encourage them to focus in this area. And then self-serving, but the HIV and aging workshop will be in DC in October. So sorry to jump in with all of that stuff, but advertising is important.
Yep. Perfect way to end it. Thanks, Scott, and certainly thank you, Sanjay, for an excellent talk. So we'll go ahead and end it. It's 9:00. Thanks everyone for attending. Don't forget to sign up for your CME credit. The code today is 1341. So thanks everyone for coming, and good luck to all of the fellow interviewees, and we will see you next week. Thank you.